We'll actually put it to a vote. This is not that long of a lecture, and at their end, there's a really cool video it's a Discovery Channel video on this guy who was like a marathon runner, really fit, very healthy guy, and how he was misdiagnosed for a long time with hemochromatosis until he basically turned orange with, the bronze disease part of it. But it's like 18, 19 minutes. So, your choices are to listen to me for the fairly short lecture portion and watch the video here, or you listen to me lecture and you cross your hearts, hope to die, you will watch the video at some point before our next lecture.
Yes. B.
That one.
B?
Yeah.
Okay, that's what I thought. All right, let you guys go study. Okay, hemochromatosis then. All right, hereditary hemochromatosis. You're going to see this as HHC. Not sure which is harder to say. Actually affects about 1 million people in the U.S. It's one of the most common genetic disorders in the U.S. It typically affects people of Northern European descent. And you guys know me and my little history thing. They're pretty sure they've traced it back to a single person about 60 to 70 generations ago in Northern Europe. That's all on ancestries.com. But so, that was a long time ago. How in the world did this not get selected out? Well, these patients typically don't have issues until after childbearing age. So there's kind of no natural selection, right? It's not like these people died before they had kids. So even though we're talking 67 generations ago, where there definitely would not have been any treatment for it, these people would have had kids before they actually had clinical manifestations and subsequently died. So very, very simply, what this disease is it causes absorption of too much iron. It's an iron overload disorder. And since we just talked about transfusion issues, that was interesting. So the excess gets stored in a lot of different organs in your skin, hence the bronze diabetes designation, some other stuff like that. Heart, liver, pancreas, joints. Men are affected more than women. I think there's a very confusing statement in your textbook. It's on the first page of this chapter, I think, and it says something about men have this disease 10 times more than women. I want to be clear, that doesn't mean that men have the genetic mutation 10 times more than women. It means that the clinical manifestations you see in men 10 times more often than women, okay? Both can be affected equally by the genetic disorder. Why? Well, because for women, we get rid of that iron. We have menses. We usually have less dietary iron intake. Okay, so we either shed the iron and we also take in less iron. So we don't either we have less symptoms or they don't show up until later on compared to men. So don't get confused by that statement in your text. Symptoms. Like everything else, it seems like we see, the early symptoms are pretty generic, non-specific. Fatigue, joint pain, God bless you, abdominal pain, loss of sex drive. That one probably sends most people to the doctor. Later symptoms, you're looking at arthritis, liver disease, diabetes, heart disease, skin discoloration. Some pretty serious effects later on in life. So progression of the disease, it's not obviously just the fact that you have this genetic disorder, but it's also related to your environmental and lifestyle factors. So the amount of dietary iron you intake, the amount of alcohol that you consume, and any type of infections that you have. All those can obviously make this disease progress faster. There's actually 4 different types of HHC, 1 through 4. 1 is the most common one. This is the one that we really see, the one we're really going to focus on. And that's caused by mutation in the HFE gene. Then you can see the other 3 types and mutations in their genes. But overall, these genes code for proteins that all do the same thing. So these genes code for proteins that are involved in the absorption, the transport, and the storage of iron. You mess them up, you got a problem. Type 1, 2, and 3 are autosomal recessive. And 4 is the only one that's autosomal dominant. Bless you.
Thank you.
Okay, so like I said, this is one of the most common genetic disorders in the United States. About 1 in 250 Caucasians in the U.S. are homozygous for this. I mean, so 1 in 250 are, right, have the disorder. They just may not have the clinical manifestations yet, or they have them very lightly. About 1 in 10 are heterozygous for it. They're carriers for it. So that's pretty high rate. I mean, look around to your neighbors here. A lot of you in here, included, could definitely be carriers. And again, like we talked about with, there was no selection here. Even the symptoms typically don't begin until you're into adulthood. About age 40 to 60 for men, and postmenopausal for women. Why do you think postmenopausal for women? Because you're not getting rid of the iron. Exactly. That was also one of the ways they figured out what to do, how to treat these patients. Type 4 has a similar time of onset for symptoms. And side note, it's also called, type 4 is also called ferroportin disease. Okay, type 2 is juvenile onset. This one's really pretty nasty. Big surprise, juvenile onset, worst disease, right? See it over and over again. These patients will often have decrease or even loss of their sex hormones by the age of 20. So they start, it seems like they at least start puberty and everything else. Normally, girls will start their menses, all that kind of stuff, and then they lose those sex hormones. So for girls, menses will even stop at some point. So big surprise if you're not losing this iron, now you have even a worse problem, right? If untreated, most of these patients will have heart disease before they're even 30. Type 3, the manifestations are kind of somewhere in between 1 and 2. Typically, the onset's before age 30. It's not quite as bad as 2. It's not quite as manageable as 1. And that's all we'll say about type 3. Okay, so how are these patients diagnosed? So one of the things you'll see on the video, and some other videos that I saw, these patients can be pretty easily misdiagnosed because they seem healthy and they're coming in with generic symptoms, right? They're coming in, they're tired, they've got some joint pain, they've got some arthralgia. Well, if you're 40 to 60 and you're starting to show some signs of arthritis or whatever, okay, that's not going to really throw red flags to any clinician, right? Go home, take a leave, suck it up. You know, take a couple of days off running. But a lot of times these symptoms will progress, and unfortunately, if they progress to the point of you having tissue damage or organ damage before it's caught, then you've got more problems. So it's pretty important to check it out for these patients. So diagnosis is a combination of clinical and lab findings. So you're looking for an elevated serum ferritin and an elevated serum transferrin saturation. There's other labs you're going to do as well for these patients, but these two you're definitely going to look for as elevated. Now, just having these two elevated doesn't mean a person has HHC, right? There could be all kinds of reasons for having this. But if you see these, and especially that serum transferrin saturation is greater than 45%, you're going to start thinking, And nowadays, you don't just have to do a liver biopsy. So probably about 15 years ago or so, the only thing you could really do was do a liver biopsy. I don't know many people who are going to voluntarily sign up for that. I mean, that's going to hurt, right? I'd rather let's just guess that this is what it is and move on with life. But nowadays, you can actually do molecular testing because there are two main variations in that HFE gene that causes the type 1 HHC. So running PCR on whole blood, 87% of people with HHC are going to come up positive one of those two variations. So it's not perfect, it's not 100%, but I'll take getting looked at 87% over liver biopsy. So again, you're going to look for signs and symptoms that the patient's having, elevated serum, ferritin, transferrin saturation, and then suspected, you're going to do the molecular testing. So, okay, your patient comes up positive. Now what do you do? Well, a big surprise when physicians realize, women don't, bless you, have quite the issue, and they have menses, and it comes up postmenopausal. What's one of the things we can do for all patients? How about therapeutic phlebotomy, right? Let's just get rid of some of this blood. Get rid of some of the iron here. So if you have a patient that's got really high serum ferritin, you're definitely going to start this. You're going to start doing this weekly, sometimes bi-weekly, especially for men, until you get that serum ferritin down to under 50 nanograms per mil. This can take months. This isn't a 1 or 2 and you're done thing. This can take quite a while to accomplish. Then once you do get there, you're still going to need maintenance phlebotomy every now and then. But this does effectively manage the disease if you start this prior to organ damage. So you can catch somebody somewhat early on before their liver's taking a hit, their heart's taking a hit, everything else is taking a hit. These people can actually live a normal life with therapeutic phlebotomy. But you're also going to do some lifestyle education with them. Right? We're going to watch the red meat. So we're going to watch our dietary iron very heavily, spinach, red meat, all those things, beans. Make sure they're not on medicinal iron or supplements, including vitamin C, which can also really affect that. They're at a higher risk for infection, so you're definitely going to tell them to avoid raw seafood. Let's not give them a good case of Vibrio from oysters. And definitely limit their alcohol intake, protect their liver as much as possible. It's already working overtime, right? Now the interesting thing though is that for patients who do have liver damage, doing a transplant on those patients hasn't even shown an increase in survival. So I don't know if they're just that far gone with other organ damage by this point. They actually didn't do a prospective study on this. They just looked back in different registries for these patients. And since there wasn't any increase, they definitely have not done any type of other trials with this. And you're definitely going to make sure these patients are up to date on the hepatitis vaccines. Last thing you want to do is put any extra work on their liver with a nice bout of hepatitis. We are almost there. You guys sure you don't want to watch the school video? Okay. So, you know, we have to find something kind of interesting. As we're sitting here talking about therapeutic phlebotomy, I thought, well, that's pretty cool. These patients can give blood all the time, right? Well, guess what? A Red Cross actually won't take it. And it's not because you can pass it on or that there's anything wrong with the blood, because there's nothing wrong with it, right? It's not like it's sickle cell disease. However, the American Red Cross has a policy that their donors may not benefit from their donation. That is part of keeping their tax-free or their tax exemption status, that you can't benefit from your donation. It'd be like going to Goodwill and them giving you cash. Well, then you can't get the tax write-off for it, right? So they'll give you a cookie and a t-shirt, but you can't get any actual clinical benefit from donating to the American Red Cross.
What if you didn't tell?
Then you're just that's just mean. I don't know, maybe when they check, they don't really check your iron, do they?
Like, I think it's one of those things you check on your long check that.
Yeah, sure it is. You're just lying.
My father-in-law, if he can't see hemochromatosis, he goes all the time and just lies.
There you go. Do not go to the Red Cross and say Dr. Lucas said it's okay to do that. But if you do, we now know that some people do. So anyway, I thought that was pretty cool, because otherwise you got to go to a lot and pay for this, right? So yeah, exactly. Well, then I started wondering too, because in Georgia, my cousins live in this little tiny town that up until even about 20 years ago, I remember hearing them doing this. They still use leeches. Like if a patient came in, like in a hypertensive crisis, or they would actually use leeches. So, you know, who knows? Maybe 100 years ago, this is what they did.
Bloodletting.
Yeah, do a little bloodletting. So, anybody wants a leech farm and start a new side business, then you don't have to lie to the American Red Cross. Just come and get some leeches, I guess. All right. Okay, lots of references. So the one before this has the link to the video. Like I said, it's about 18, 19 minutes long. It was pretty cool because this guy was really healthy. He was a runner, you know, he's somebody normal that you would see come into clinic that, you know, he thought he was crazy, his wife thought he was getting crazy, the doctor saw it, and then it actually turned out to be something that could be managed. So it's a cool video. Questions? No. Okay. Next lecture. When are we together next? Let's see. Let me tell you what we're going to look at, so you'll know what to read. I think we're together next. No, I have another week. Oh man, you guys are like not till the 22nd again, huh? Okay, 22nd and 24th. All right. So what are we going to put together for those?